Any questions?
As you mentioned, in case of air leak also we can go for non-invasive mode of ventilation.
Yes.
But then question is sedation, sir. If the baby is intubated, we generally completely sedate because we don't want baby to fight a lot. Because
I don't
air leak
agree
is
with that.
there.
Next is sedation. We'll discuss that.
Okay.
I don't sedate the babies just because they have an air leak.
Okay. But generally also in
We
ventilator,
will discuss
don't-
sedation next. Yeah. Yes, Rishita.
Other thing we discussed is in non-invasive ventilations, if you give more pressures when the baby has an ICD in situ, there's a high chances of having a pneumothorax, continuous pneumothorax. But in what situations do you consider, suppose the baby has been term baby, ventilated for the pneumothorax, chest and in situ, 48 hours baby, 24 to 48 hours baby has been stable. You have deep extubated the baby had mild distress, so you put the baby on HFNC. You see that in 6 hours, in 4 to 6 hours, baby has deteriorated on HFNC. Then do you recommend the baby to go back to intubation or put on CPAP?
You can try CPAP or NIPPV. I mean, make sure you repeat an X-ray to make sure it's not the air that's reaccumulating. If you need air reaccumulation, you can connect negative suction for a period and manage. So sometimes there is pockets of air. You may need needling on top of the chest. So as I said, you need to be confident in your decision. Don't be passive. Be active in your thinking. Don't be negative in your approach. Be confident in the decision making. That's all. So I agree that it's not easy, especially in inexperienced hands. So sometimes we tend to act on the side of caution. But you keep doing that and you keep doing that for life, isn't it? So you need to make a sensible decision and you need to consider all the parameters. So you have to train yourself to think in a systematic way. So you have to put all the points to consider in the balance. Excessive sedation is something that makes you keep the baby intubated. Again, sedation itself causes side effects. We will discuss that as well. So sedation is not free of side effects. It makes your requirements more than less.
Question.
Yeah.
Sir, we recently had a baby who had pneumothorax, preterm baby at birth.
Yes.
So baby was deteriorating. We put an ICD, but started with HFOV mode of ventilation. What do you recommend, sir, in a baby who has air leak since birth?
It's okay to start with high frequency. High frequency is gentler, and as I said, the shear stress is going to keep the pneumothorax open. The same reason we said don't avoid extubation or don't intubate just because you have an air leak. If you have an air leak from birth, and also after you recruit the lung, you have to decide whether you need surfactant or as well. So in a premature baby with the RDS and a pneumothorax, I mean, you may have to be cautious with the use of surfactant. If the lung is open, you may aggravate the pneumothorax if there is excessive opening up as well. So if the baby needs, the oxygen requirement is high, you're not able to open up, or you need high pressures on high frequency, you give the surfactant as well. So that wouldn't differ.
Bronchopleural fistulas, like they will continuous, and what type of?
That's a different story. I mean, it's probably not a common scenario, but it's very difficult to manage because you can't remove the chest drain in many of those babies, and very rarely you need a surgical input. But the idea is to prevent any bronchopleural fistula happening in the first place. So by appropriate use, and don't overuse the negative suction as well unless you need it. Non-invasive ventilation is probably going to be better, but in a premature baby with RDS, you probably have to intubate such babies as well, but don't overdo ventilation. And high frequency is better because we will discuss high frequency, it's gentler. So the movement back and forth is less.
Same case, sir. So we extubated the baby within around 72 hours, but then we had kept the ICD. So what is your say in this, sir? What about how do we manage ICD and then ET? Is there?
We discussed that already. You have to make a decision based on the case. It's okay to do that. So you can decide to keep the ICD if the air leak was significant till you extubate and baby is stable. Then you clamp and remove the chest drain. But if the baby is a premature baby and had a pneumothorax from birth, you don't know how the lung will behave because the baby is already premature. So in a premature baby, I may tend to remove the chest drain first. You don't want to re-intubate such a baby because the likelihood of re-intubation is more in a premature baby. So if it's a very premature baby, I would probably remove the chest drain first. But you have case-by-case decision, weight, gestation, everything matters. So I cannot comment on that case. But you have to That's one of the points you'll consider. Is it a small baby? Is there a risk of IVH here in the first 3 days? A worsening and re-intubation is not ideal as well. You have atelectotrauma and so on. So that's part of the equation. So you will be weighing it yourself. Every case is different. But it's not wrong to extubate the baby before the chest drain, but according to the scenario. So